Hi, my name is Richard Isaacson. I'm director of the Alzheimer's Prevention Clinic at Weill Cornell Medicine and New York Presbyterian. Today, we're going to be talking about endpoints in Alzheimer's disease clinical trials. Let's talk about the Columbia Suicide Severity Rating Scale. The C-SSRS, or Columbia Suicide Severity Rating Scale, is a very commonly used safety outcome that's used across the fields of both neurology and psychiatry to prospectively measure the severity and frequency of suicidal ideation and suicidal behavior. And this assessment is not just used in dementia trials, for example, but it can be used with studies for headache, studies for psychiatric drugs, studies for other drugs across a host of conditions, in fact. And the components are actually pretty straightforward. When it talks about the severity of the ideation of potential suicidality, you just answer yes or no to the following questions. 1, do you wish to be dead? 2, do you have non-specific active suicidal thoughts? 3, do you have suicidal thoughts with methods? 4, do you have suicidal intent? Or 5, suicidal intent with a plan? And this severity of ideation is really critical in trying to understand what could the potential adverse events of a drug or treatment for Alzheimer's disease be when it comes to using in clinical practice. And this is something that's quite important to try to understand these aspects. When it comes to the intensity of the ideation, we need to understand in terms of a 5-point scale, the least severe being 1, 5 points being the most severe, in terms of the frequency, the duration, the controllability, the deterrence, and the reason for ideation in terms of why a treatment may be increasing or affecting suicidal ideation or behavior. When it comes to the behavior subscale, again, also yes or no. Is there actual, aborted, interrupted attempts, preparatory behavior? These are all things that are quite important to really get a pure sense on because of the seriousness of this potential adverse effect. Also, there's also a lethality scale or a subscale, including the actual lethality, medical damage. It's on a 6-point scale, 0 meaning no or minor physical damage, to 5 actually being death. So when it comes to the scale, it has multiple components, but the components are necessary because it really gets to the heart of the matter of the really severity and intensity of the potential adverse event of the drug being studied. When it comes to the advantages, well, this is a really important safety assessment, and it can be done by anyone. It can be done by raters, non-experts in behavioral health. Therefore, it can be useful in daily practice. That being said, even though it's not useful, even though it's maybe useful, it's not really routinely used in clinical practice. And most clinicians may ask maybe 1 or 2 questions related to suicidality and intent, but going through the entire scale is not often practical. It also does not adequately reflect patient outcomes and can be inferior to a standard risk assessment. Further, the scale is not validated in elderly populations, and there have been some concerns raised on truly, is this an appropriate scale to be used in patients with dementia, or is this better to be used in younger people, healthier people with no other clear medical or psychiatric comorbidities?